Welcome to the Iconic Podcast with me, Soon Yu, your host. The Iconic Podcast features candid conversations with successful Asian and AAPI leaders who share their personal journeys of challenges and triumphs. The Iconic Podcast is brought to you by the Asian American Foundation, by Gold House, and by the founders of the Asian Alumni Chapter of the Stanford Graduate School of Business, and is made possible through the generous support of Altos Ventures.
A couple of years ago, again, before my diagnosis, we chose to prioritize lung cancer and never smokers as our, what we call moonshot project, where we're really trying to move the needle in this area. And again, irony of all ironies, I become the poster child for this disease.
Welcome to the Iconic Podcast. I have the incredible honor of welcoming Dr. Bryant Lin to our show today. Bryant, you've given me the grace to call you by your first name. Obviously, I was raised Asian, and when we meet people of stature, we always call them by titles, right? Especially when you meet doctors. And so, Bryant, it's a really an honor and a pleasure to have you on the podcast. Thank you for joining us today.
Great, thanks for having me. You know, it's funny when I trained in Boston, and you always think of Boston as being a formal place, but you know, where I trained at Tufts, people are very informal, and you know, we called each other by our first names, even the very senior attendings. So, you know, it's always a little odd to me when people call me Dr. Lin, unless they're my patient. So that's okay then. But if you're not my patient, just please call me Brian. Actually, even if you're my patient, just please call me Brian.
That's good to know. Well, Bryant, first off, let me introduce you to the audience and also kind of give a little context why today's episode is really actually important for me because it hits close to home. We're going to be talking about the idea of lung cancer, especially in the Asian population. My mother was a non-smoker, and a few years ago, she also passed away from lung cancer. So again, this topic is very close to home for me. For those of you who don't know, Bryant, I was going to say Dr. Lin. Okay, Bryant, I mean, because you've availed yourself to basically New York Times, Washington Post. I don't know how many podcasts you've been on, how many YouTube videos there are of your story. It's out there, but I do want us to have the opportunity to share it on this platform because there might be folks that might not have heard of it, and also specifically because this is very much targeted to the AAPI community. But you are a primary care physician practicing at Stanford. And beyond that, you're kind of a triple threat. You are a researcher, and importantly, you are an instructor. You are also the director of Medical Humanities and Arts. You're the co-founder for CARE, which is the Center for Asian Health Research and Education. And specifically, the idea of lung cancer hits our community probably harder than most communities. And so, again, very apropos. What's very, maybe not as well written about you, you are actually an inventor. You're an innovator. You have founded 3 or 4 companies. A couple have actually been acquired. You're working on one now I think is really interesting about sonic waves. And so, I mean, that part of you may not be well written, but just as a entrepreneur and an innovator, that's a big part of what you've contributed also. I think you've taught some really interesting classes at Stanford. Storytelling in medicine, obviously lots on Gen I. Your probably most famous class right now is is Med 275. I think that is probably going to be a seminal class that people will always refer to, but it's From Diagnosis to Dialogue, a doctor's real-time battle with cancer. And obviously from this title, and if you've read the description for this podcast, you'll know that what I find very, I think, extraordinary is your courage, your willingness to share with everybody the story that you're going through right now, and especially given there's a physical toll to going through chemotherapy, but you are leading by purpose, which again we'll talk about both from the CARES perspective, but also potentially on improving the face of medicine and how we treat patients. And again, you're this hero that's saving us by really sharing your humanity and your story. And I'm very much grateful for your time, because I think that the dimension of time has dramatically changed since your diagnosis. And so let's just start there. Let's start with your diagnosis. What happened? This was about a year ago. And can you kind of walk us through what was happening beforehand than the actual diagnosis and sort of, how you dealt with that.
First of all, thank you for inviting me to your podcast. And, absolutely, I think, it's so important to bring information and also a conversation around Asian health to, our Asian community. So thank you for having your podcast, and thank you for having me. Last year, so I got diagnosed on May 13th of last year. That was the day my pathology came back. About 6 weeks prior, I started to have a nagging cough. Cough, cough, cough. I thought, oh, it's allergies. Usually got spring allergies. I never had a cough related to my allergies, but I thought, oh, maybe I'm starting to develop a little asthma from my allergies. Tried, different allergy medications, inhalers, inhaled steroids, even antibiotics because the cough was persisting. And then because it was just not going away, now, we're at basically 5 weeks in a day, I got a chest x-ray. So this was a Tuesday, I think it was May 7th, and showed a big white patch in my right lung. So what we call it opacity. And geez, what is that from? Is it an infection? Is it an unusual infection? Is it cancer? What type of cancer is it, if it's a cancer? Next day, I had a CT scan, which showed, again, big opacity, fluid in my lung, and the lymph nodes in my chest lit up. And so, what is this? On a Friday, had a bronchoscopy. They went in and took samples from the lymph nodes. And by Monday, I had a pathological diagnosis of lung adenocarcinoma, so non-small cell lung cancer. So that was just an incredible experience, shock. I think you used the word irony. I co-founded the center. And since day one, lung cancer in never smoking Asians has been an area that we have tried to support in terms of research and education. A couple of years ago, again, before my diagnosis, we chose to prioritize lung cancer in never smokers as our what we call moonshot project, where we're really trying to move the needle in this area. And again, irony of all ironies, I become the poster child for this disease.
Yeah, there is irony in that. And also, I think you even talked about this idea of serendipity. And usually people use serendipity as sort of well-fated or positive fate. And yet you talk about the idea there's a certain degree of fate or destiny in you being put in this position, as unfortunate as it is. One thing I noted is you went from sort of, I think, first sort of analysis to actually getting a diagnosis within 6 days.
Yes.
That's unheard of. I mean, you got an X-ray, you got a C scan or CAT scan. You did the scope, I believe. Is that right? Right. Yeah. And I bet later, that point, they could probably tell you it was cancer. Were they able to tell you the stage at that point, or was that
then you need a PET scan typically to determine the extent that it's spread, because there's 4 stages for most types of cancer. Yeah, I wouldn't say it's unheard of, but it's amazing, and really a tribute to the amazing care I've been getting at Stanford and my colleagues. But as I say all the time, even though this my experience should not be the exception, it should be the rule. Everyone should be able to get a really expedited diagnosis when they're going through this. And, not because anybody doesn't want that, just there are a lot of systematic issues at play, right? It's hard to get appointments. We have poor access. There are insurance issues. You got to get insurance approval. Of course, we don't work on the weekend, which is great. We shouldn't work on the weekend, but bronchoscopies are not done on the weekend. We don't. PET scans sometimes take a while to schedule, right? Because they can only do so many during the day because there's a radioisotope involved. There's a lot of barriers to care. I happen to be very privileged. I happen to be in every area. I don't have a barrier to care. So, in our class, we talked about this. We had a whole session on access. So, when I asked the students, I said, hey, what are the privileges I have that maybe a lot of the patients, a lot of the, typical patients don't have? And, of course, insurance, transportation. I've got great family support. I've got a flexible job. I've got good income. I've got, of course, next to an oncologist, I'm a primary care doctor. I have great health literacy, right? I know about cancer. I'm a doctor, right? One thing that was interesting that, and this is, great for this audience, is that the students didn't think of, but I brought up to them, and it's a huge barrier, is I speak English. So I think about my parents who are immigrants from Taiwan. They speak English, but, heavily accented English sometimes, and, don't have great health literacy or don't understand necessarily the Western framework of health. Of course, that's why two of their kids became doctors. This is always what happens. And, that is really important. The fact that I speak English as a first language and I speak fluently, really is an access barrier that many people have, right? Many people in the Asian community, or could be, the listeners, could be the listeners' parents. It's a huge barrier. So, I wanted to raise awareness of all these barriers by showing that if you don't have these barriers, if we can address these barriers, like in my case, I happen to have, again, be very privileged and not have any of these barriers, what can be done in medicine, how well we can take care of people. So, I think every system is trying to do this. There's a lot of challenges in the way the systems are set up and all the, confusing aspects of the U.S. healthcare system.
Well, I'm so glad you actually have a whole class dedicated to the idea of accessibility and access. And I feel like not only every medical student should be watching that, every hospital administrator, every insurance provider, anyone related to the entire healthcare system, because they're all sort of part of this. And just so you know, when you talked about the idea of English being such a big barrier, I have great empathy because I had role reversal. My dad last year passed away, and he was in Taiwan at the time. And so, totally different healthcare system. My Mandarin isn't that great, okay? It's okay. It's passing. Thank God for my wife, who's obviously native. But, it was very difficult having, trying to have Skype conversations. We're usually 2 or 3 in the morning, so it's the time when they were actually doing the examinations. And that was at least twice, 3 times a week with my sister. And it was a very difficult thing to try to understand medical, I think, issues and then have enough information for decision support, because they were asking us to make the decisions, right? In a language that wasn't native for me. And so I can, and like you said, there are probably a lot of folks, and especially the elder portion of our community, whose English is not maybe, up to par with medical standards, right? And so, yes.
Or they don't speak English at all. I have lots of patients come in, they're Asian, from China, from Taiwan, from Japan, from Korea, from Southeast Asia, from India, who really speak minimal English. And they bring a family member, even though we have translators available on video for them. Of course, usually they bring a family member, not necessarily to translate, but of course they're there to translate, but also, to capture the information, to digest it, to relay it, to really help them manage their care. We had a whole session on caregiving in our class as well, and the importance of that. As you mentioned, my wife was one of the panelists on the caregiving session. But, like you are, I'm also a caregiver for my parents, my aging parents. And, for the Asian community, there's so many differences culturally in our goals and kind of biases and, wishes and dreams for our lives and, how we interact with our family and, how we receive care or how we want to receive care. So, that's all very important, and we're all so different. And the system kind of is set up as a one-size-fits-all system, right? But we know from the Asian community, it's not a one-size-fits-all when you're in the U.S. And, just like your example, when you're in Taiwan, it's also the same, right? There may be other barriers or other challenges that get in the way culturally, language-wise.
Absolutely. I kind of want to go back to the idea of the diagnosis and what happened afterwards. After those 6 days passed, you got that diagnosis. Did they give you the stage at that point, or did you?
No. So
what happened?
Yeah, the PET scanning, as I mentioned, God, it takes some time. So, that Monday, I think I had the PET scan and the molecular testing. I think that was that following Friday. At that point, I had staging then, And then I had the molecular testing back, which is really important. So this is this new era of precision medicine we have. So you can test the tumor for genetic mutation. What's the cancer? What's the gene mutation? What's the oncogene that is driving the cancer? And for me, it was EGFR, epidermal growth factor.
EGFR, right?
So this is the kind of
Can you explain that to the audience?
Yeah.
What EGFR is?
yeah, absolutely. This is the common mutation that is, in 50% of Asians who don't smoke with lung cancer, they have this mutation. There are different submutations. So there's a mutation in this epidermal growth factor receptor. So it's a big protein. It crosses the membrane. It's a transmembrane protein. It's a receptor. And the mutation occurs actually on the part that's inside the cell. And it causes it to go haywire, right? It becomes cancerous, it reproduces. I have actually the most common submutation of the EGFR, which is exon 19 deletion. And so for me, luckily, I am a great candidate for targeted therapy, precision therapy. So a drug called Tagrisso or osimertinib. And this is a really amazing result of years of research dating back over 25 years ago, when the first tyrosine kinase inhibitor, this class of drugs are called tyrosine kinase inhibitors, was developed. The first one was called Gleevec. And it was amazing. It was a miracle. I remember in medical school, I learned about it. It was just being approved at that time and being used. And it seemed like a miracle drug. And little did I know, 27 years or however long it's been since I started medical school, later, I would be the beneficiary. And that's why I can speak to you today. I'm not coughing much, not short of breath. I can have a conversation and, drone on and on and on and, not have to catch my breath. And that's a tribute to this drug. So research is really, really important. I know I wanted to point this out because, now with all these challenges at NIH and funding cuts, I worry that we're going to miss a generation of both science and scientists, and that's going to directly impact people like me, in a few years, because this drug is not going to last forever. People inevitably develop resistance, so the tumor develops resistance to the drug. And so maybe I get 1-2 years out of this, hopefully more. But that at that point, when resistance occurs, I need to have another option. And it's not clear what to do next. There's no standard what to do next. But, I want to have a lot of choices. I worry with this lack of funding now, in 2 or 3 years, when I need something new, it's not going to be there because nobody funded it.
During the height of the Asian hate crimes, I was left with a sense of disbelief and anger. These feelings prompted me to write a Forbes article titled, "Who Owns the AAPI Brand?" It's clear that branding such a diverse community is difficult. Yet in the absence of a cohesive brand narrative, derogatory stereotypes and racial slurs were created. Fortunately, the AAPI community did come together and form TAF, the Asian American Foundation, to not only combat Asian hate, but to also share positive narratives that fight bias and promote belonging. TAF has launched numerous programs to support this effort, including the Iconic Podcast. Please visit TAF.org to learn more, and to subscribe to this podcast, please visit iconicpodcast.com. Join me in supporting TAF, because together we make a difference.
We think frequently about terminal cancer because of the name terminal, right? The word terminal. It's about dying, right? But it's not really about dying. It's really about living. How do you live life when you have limited time or less time than you thought you had before?
There's a lot I want the audience to sort of pause, and there's a lot to take away from this. First, and I obviously, watched a lot of the classes that you've taught. And one of the big takeaways is that lung cancer is the number one cause of fatalities from cancer.
Cancer-related death in the U.S.
Cancer-related death.
And the world.
Yeah.
Excuse me.
Bless you. Okay.
Yeah. I do have allergies.
You do have allergies, which I think was part of the reason you had the diagnosis and thinking it might be, I don't know, post-nasal drip or something, right?
Absolutely.
Okay, so that's point number one. Point number two, index is incredibly high within the Asian community, and specifically with women, for lung cancer caused for that was not driven by, call it, smoking, right?
Yeah.
Okay,
So about
so it's really
twice,
really high.
yeah, for Asian women have twice the risk in some studies than non-Asian women to have lung cancer as a non-smoker.
All right.
So,
And as a community, we tend to have higher, I guess, is the mutation of the EGRF or
yes.
FR, right? And so that's a cause of it. Okay. And I think one of the biggest takeaways I also got was this idea, and it's applied to me. I'm having this weekend, I'll see my sister. And because our mother passed away from lung cancer from a non-smoking sort of environment, there is a much higher likelihood based on family genetics that we have that mutation. Is that sort of a fair conclusion?
So I just want to clarify. So this can be confusing. So the mutation is a mutation in the tumor, and it is driving the replication of the cancer cells. It's not what we call a germline mutation. It's not an inherited mutation. However, exactly as you said, the family history, as far as we know, seems to be the number one risk factor in patients with lung cancer who've never smoked. Okay. Whereas, of course, in smokers, the number one risk factor is smoking. That's very clear. So we don't know what genes, group of genes, expression of genes increases the risk for this cancer and results in this mutation. So this is where it's a little bit complicated in that, yes, family history is a risk. Yes, there's a gene mutation, but that gene mutation is not one the one that we know about is not one that's inherited. It's a result of some chain of events that is not clear to us.
And part of my takeaway on a personal level is I should probably get screened. I'm over 55. I mean, my mother had it. Obviously, my sister, even more so, given that she's female. And I think that's something that I guess what I want to share with the audience is that look at your pre-existing conditions, your family history, the fact that you are Asian, and the conditions that you live in, and have a conversation with your physician on whether or not you should get a screening. Because if you have a family history, what we're saying right now is go get screened.
Yeah, so this is a very challenging area. So I totally agree with you. I think people should go get screened. It's challenging because we don't have guidelines that recommend screening in the US. Okay. In Taiwan, they are doing screening, for anyone who's at risk, and it's covered by the government. In the US, because things are insurance based, screening tests are covered if there is a guideline from the US Preventive Services Task Force that says, hey, we do recommend the screening, like mammograms, like colonoscopies, right? Those are all on the standard guideline list. Unfortunately, it's challenging. That organization is very conservative. They want a high level of evidence in the US to really say, hey, we can make this recommendation. So at CARE, we are trying to work with various groups and investigators, and my colleague, Dr. Natalie Louie, is leading the charge to develop more evidence in the US to support screening for Asians in the US. So of course, if insurance doesn't cover it, what do you do? Well, unfortunately, you have to pay out of pocket. So, for some patients, that's possible. For many patients, that's not possible. So yeah, I agree with you. Absolutely get screened. And then the other question is who should get screened? So, in the Taiwan study, it was 55 plus with these risk factors. I was diagnosed at age 49, Mm-hmm. So, because we don't have guidelines, actually my center with my name on it, I said, Dr. Bryant Lin recommends this. So to me, I think if you're above the age of 45, whether you're a man or a woman, and you have a family history, you should definitely get screened with a low dose CT. A lot of primary care docs, there's another barrier. You have to have that ordered by a doctor, right? A lot of primary care docs, my colleagues, not my colleagues at Stanford, but my broader colleagues in the world, don't necessarily know about this. Don't necessarily know that Asians have a higher risk. Don't necessarily know about the talent study. So it will take some education to have them order that. Because, they worry appropriately about things like radiation exposure, false positives and incidental findings, right? So this is why we definitely need more research. But from my perspective, I think we can start saving lives now by screening people.
I think this may go without saying, but I'm going to say it. The reason you screen is generally, you'll catch it earlier stage versus later stage. And stage 1 through 3, the survival rates are much higher than
Absolutely.
if you were to catch it much later. Let's go to your stage 4 diagnosis. I think your quote was the crap was everywhere. Well, kind of explain how you got to that statement.
Yeah. So yeah, stage 4 at 5 years has roughly, if you look at historic studies, stage 4 non-small cell lung cancer, which means it's spread widely in the body, has about a 9 to 10% survival rate at 5 years, something in that ballpark. That doesn't include these new drugs and new treatment regimens. I'm a beneficiary not only of the new drug, relatively new drug, it's not that new anymore, but also of new treatment regimens. So there was a study, I think the fall before I got diagnosed, that showed that chemotherapy plus Tagrisso osimertinib was better than Tagrisso osimertinib, that drug alone. So, so I don't exactly know. We don't have results from that study which show what was the overall survival rate, because it's ongoing. They're still observing people, right? So stage 4, I had spread to my brain. I had 50 spots in my brain.
50.
Oh,
That's
55 zero.
very unusual, right?
Yeah, I felt sorry for the radiologist. I'm like, God, poor radiologist. He had to count 50 spots because he specifically, I'm sure, it's not an exact count, but, he counted at least 50 spots. So, I spent some time to do that rather than think there's numerous metastases. Fortunately, I've responded well. Those are gone, not detectable on MRI.
By the way, 50 in the brain meant you probably had a whole bunch elsewhere too. Is that right?
Yeah. So I had, of course, in the lung, in the lymph nodes, in the liver. I had spots on my adrenal glands. I even had lumps under my skin. I thought they were lymph nodes, but I actually had, the pathologist did a fine needle aspiration, and in real time showed me on the slide, hey, these are all adenocarcinoma. They're not even lymph nodes. I had no idea that you could get little lumps of cancer under your skin that weren't lymph nodes.
It's spread everywhere.
Oh yeah,
Wow.
it's definitely spread everywhere. And luckily I responded to treatment. I still have the cancer, still have 2 major areas in my lung, lymph nodes, possibly the bone, and as well as a spot on my liver. So I get scans about every 3 months. And, last scan was early May, and luckily no change. Maybe some slight improvement. I had collapse of my right upper lobe, my right upper lung, and that seems to have re-aerated to a certain extent. So I'm happy to see that as well.
Okay, that's great.
But
Yeah.
again, it's not gone by any means, and at some point, hopefully not for years and years, but could be tomorrow, could be in a month, could be in a year, my tumor will become resistant to my therapy, and so then I need to seek something else.
Got it. So you did chemo, and now you also have therapy drugs, and the combination.
Still getting chemo.
You're still doing chemo. Okay,
Yeah.
got it. Couple thoughts on that. I've been able to watch a couple of your classes, and what I was most struck by was how your perspective on being a physician has changed. I mean, and in many ways, you were already set up to probably be more predisposed to think about the human side of medicine. I mean, obviously, you're the director of the humanities and arts component of it, which is really infusing art, literature, philosophy, music, all types of things that aren't necessarily related to medicine into medicine and the practice of medicine. And I'm just curious, even though you had that bent to sort of have much more of an empathetic point of view on what it was like or what it might be like to be a patient, now that you are the subject matter, how has that changed your perspective in terms of treating patients and thinking about treatment itself?
Yeah, I always use this phrase, I knew, but I didn't know. We theoretically know as doctors, and, we get trained and we teach medical students, what part of what the patient experience is like, but, it's always incomplete, right? You can never capture the whole experience. But, I always believed in the importance of humanity, of the human-centered aspect of medicine. When I became director of medical humanities and the arts, I went around and talked to 100 people in the community and, asked them, hey, trying to figure out, hey, what's our mission? What should our mission be? What should our vision be? What are our goals for our program? And it was interesting. What we really settled on was not an academic definition. So a lot of other universities have a very academic definition of medical humanities, or some people call it the health humanities. And we settled on really the core principle is human connection. Not just medical humanities, but all of medicine is really in support of that human connection, connecting between two people. And not necessarily doctor and patient, could be doctor and patient, but even patient and caregiver, right? Could be, that aspect is still part of medicine, right? So it's really a human connection between two people or more than two people, right? And all this technology, all the AI, all the tests, all the drugs, it's just in service of that connection, right? We don't treat everybody the same because everybody has different goals, different wishes, right? Different concerns, different fears, right? So we have a bag of tools to offer them. And we really need to have that human connection to help work with them to figure out what to do next, how to manage their symptoms, how to manage their medical issues, and help them achieve their goals.
Yeah, obviously, being a patient, you have great empathy for what it's like now to be a patient, and also, it's interesting. Now you understand what a doctor has said to you and why the doctor said it, but you also now understand how it's actually received and what there might be some lost in translation between what the doctor intends and what the patient actually receives. And I think that is really fascinating. You also talk about,
But I have the advantage of, self-interpreting, right? So,
of course, that's your world, yes.
yeah, do I truly know what a patient who doesn't have this grounding in health knowledge goes through? I don't, right? Because
Right.
I have that knowledge, so I can go and ask and
Yeah.
ask the right questions, so-called right questions at the right time. But so that's a challenge that I haven't had to go through. Again, I have all this privilege, even though I'm experiencing life as a patient. And I'm a kind of a very rarefied patient in that, I have all these advantages that most patients do not.
That's fair. In some ways, having all that knowledge also could be a curse in the sense that you may have already come to certain conclusions and jumped ahead sometimes, maybe. But
Yeah.
I do think the one thing I thought was very fascinating is how you talked about the concept of hope and how you saw it one way and now you have. I don't think it's totally different, but you maybe have a more advanced thinking on the idea of hope and dealing with patients. Can you talk a little bit about that?
I don't think I see hope itself as different, but I do see the role hope plays. I'm much more aware, much more conscious of the role hope plays with patients. In medicine, especially in an academic institution like Stanford, we really try to be evidence-based and talk about the evidence. But, that sometimes can come across as, not providing, very neutral, very dry, not providing hope. We study medicine and we study populations. And we use that information from populations and try to apply them to individuals. But, we don't necessarily know what's going to happen to that particular individual. So I think that's a type of hope. Another type of hope is one of my friends from medical school, one of my classmates, he introduced me to a pulmonologist, one of his colleagues, who had the same type of lung cancer. And he made this great comment to me early on, which I carry with me. He said, you just have to survive long enough till the next treatment comes out. So, that's another type of hope, right? It's not unfair. You have to be balanced, right? You don't want to give people false hope. But that, to me, that's a true hope, right, to have. It's like, hey, I don't know what's going to happen in the future. If I need something, there may be something new there for me. I don't know what's going to happen in the future. I may be one of the 90% who dies, but I also may be out in the 10% that lives, right? So there are different aspects of this hope. I think you want to have hope balanced with reality, but I do believe, to me, I've come on a better balance of hope when I talk to my patients, not to make sure, and I go out of my way to make sure I don't accidentally, unintentionally take away their hope.
Yeah, I think that's really helpful because you're right. Sometimes you look at odds, and so you lean where the odds are better versus, hey, it might be more individual, or quite frankly, many people beat odds, right? And that's why their odds are not 100%, right?
No.
The other perspective I think is so important is the idea of call it frame of reference. This idea that, hey, you just need to survive to the next advancement in technology or medicine or whatever it might be. And I think that's such a really I think healthy way to even think about living your own life in some ways. And so that's great. You also talked about the importance of storytelling and spirituality, and I think nutrition, and there's just so many other elements of what I call giving care to people than just pure medicine and treatments. And so, can you talk about this full spectrum that you're now sort of teaching in your class in terms of what it means to actually care for somebody?
Yeah, just to be clear, I taught the class in the fall, not continuing to teach it. I'm not going to teach it again. It was in retrospect, it was an emotionally draining experience. And so, I'm happy it was recorded. It's available on YouTube for anyone to see.
All 10 episodes,
Yeah,
they're there, right?
Yeah,
Yep.
10 sessions, all 10 classes. We intentionally designed the class so around half of the sessions were really focused on topics that are near and dear to patients, that really reflect the patient experience. When we see patients in the clinic, right, we see them getting treatment in the clinic, getting tests, getting blood tests, getting treatment, we get picking up their medication. That's a tiny percentage of their day, right? That's a tiny percentage of their life. They're living the rest of their life, worrying about spiritual matters, right? Getting care at home by their family, their friends, or some people by no one. They worry about access, right? How do we pay for this? How do I pay for my medication? How do I get my copay, right? And then they also worry about their mental health, right? They may get depressed, they may get sad. We really wanted to make sure the class was balanced around those human patient topics and not solely on the science, the basic science, the research, the clinical aspects, just because students get enough of that, and they're going to always get tons of that throughout their training again and again and again. I'm not worried that they're not going to learn that part, right? But I think it's important that they get exposed early on to the human side of what a patient goes through, and specifically around topics that are related to their life, living their life, right? We think frequently about terminal cancer because of the name terminal, right? The word terminal, it's about dying, right? But it's not really about dying. It's really about living. How do you live life when you have limited time or less time than you thought you had before, right? And how do you have a good quality of life? How do you reach your goals in that time, right? Which is still uncertain, right? Like I said, we're really bad at predicting things in medicine on an individual basis. But we do know that highly likely, your lifespan is shortened. Do we know how long it's shortened? No. But in that time remaining, we really should be trying to, and I think we all do, all my, medical profession, to try to, make that the best life and make sure that the patient gets everything that they need or want to do during that time within our capability.
I'm really grateful that you did record it, because maybe somebody might not teach that class or that type of class for a long time. It might be one of a kind for a while. And
I hope nobody ever has to teach that class. I
Yeah.
hope that our technology advances to the point where, we may get cancer, but then it's not a big deal, right? It's a chronic disease or it's curable, right? I think that's the hope for the future. Can cancer become like high blood pressure or diabetes, something that we're like, oh, I've got diabetes, I'm on medications, it's controlling it, right? I don't have to worry about it too much, right? I can live my life. But cancer, is not that case, right? Not yet. I think we're making great strides. It's still not quite there yet. We're not at the point where all cancers are chronic diseases, but my hope is there that we'll get there and nobody will have to teach a class like mine in the future.
Yeah. That's true. But I do appreciate the idea of all the topics you tackled and how you thought about the full spectrum of what it meant to give care. And the fact that your wife and came and spoke and she talked about the importance of both patience, both being in the moment because you just don't know what's going to be around the corner, but also sort of having a loose plan for what needs to happen and having both of those roles that people are playing. Are you ready to be part of a community that amplifies the voices of Asian leaders in business, government, and the arts? The founders of this podcast are members of the Asian Alumni Chapter of the Stanford Graduate School of Business, whose mission is to empower Asian and AAPI voices in our community. By subscribing to this podcast, you'll stay up to date on the latest Iconic episodes, and importantly, gain exclusive invitations to select Stanford Asian alumni events that can provide useful insights and a powerful network to help you on your personal and professional journeys. Go to iconicpodcast.com and subscribe today. Join us and be a part of a community that's shaping the future of Asian leadership. I was really struck by a lot of the stories that you shared in each of the classes, and you even teach a class on storytelling. Talk about one of the stories, I think this was in the first class you read, from a patient. And why that really hit home for me is I think that patient, their family had to make a decision to pull them off of dialysis. We had to have the same conversation with the doctors in Taiwan for my father. So I fully, when you read that, it just really hit home. But can you talk about the stories, and then let's talk about the story of the letter that you're writing to your sons or have written. So can you talk about this idea of the power story?
Stories are how we communicate. We're humans. Again, what makes us human? Well, one thing humans do that, that we know of, animals don't communicate in story, right? Machines don't communicate in story, right? Maybe future AI will, who knows? But we are wired for storytelling. Lots of evidence that shows that if you talking to a patient or you're trying to persuade somebody about something, telling a story is much better than giving somebody statistics alone. And probably both is even better. Giving them the kind of the statistics about why they should do something, make a behavioral change. But telling a story is really powerful. And that's why I started the class with a story. For years, I didn't have a great kind of, I had kind of a canned, boring answer to why I went to medicine. And, as you mentioned, I had a patient, he had chronic kidney disease and was not planning on starting dialysis, but, his family wasn't ready to let go. And, he said, okay, I want to spend some more time with my family as well. And he went on dialysis, had a tough time, and we had another family meeting, decided to withdraw dialysis. And I got a letter from him, very kind letter, said, thank you, Dr. Lin, for taking care of me.
Actually, I have it. I'm going to read it real quick. KK said that this is your words, but from him, right? Obviously. Yes. Dear Dr. Lin, I wanted to thank you for taking such good care of me in my old age. You treated me as you would treat your own father, with humor and care and great professional skills.
It's amazing, the fact that somebody who I knew quite well as a patient and as a person would spend their last days and this is also a reflection of the kind of person he was, was always well-dressed, prepared, very polite, that he would spend time in his last days to send me a letter, and a letter of thanks and gratitude, really touched me deeply. But to me now that story becomes a explanation of why I went to medicine, why I went to primary care specifically, right? Very rarely in life do you get a chance to develop that kind of a relationship with somebody as part of your job, as part of your profession. Maybe priests do and religious folks, but doctors, healthcare providers were there, at crucial inflection points in people's lives, right? At birth, at illness, good times, bad times, at death. It's kind of an amazing thing that we have this honor and privilege. So I was honored and privileged to have taken care of him during his last years. And yeah, this is something where stories, me telling that story, is much more powerful than giving a, academic philosophical discussion about why I went to medicine, right? About why stories are important. I can just tell that story, and then hopefully people realize, hey, that's powerful. That's why stories are important.
Yeah, I love these. It sort of gives you explains your motivation, right? The whole story of that patient that wrote to you. It also gives you examples and motivation to potentially change or have new directions. And I also love that a lot of your students talked about attending your class, hearing those stories, and hearing your story allowed them to process feelings and emotions and I call it baggage that they've had about their own situation with cancer or dealing with family members that had cancer because it allowed them to live their emotions through you and process those emotions. And so I think you're right. The power of storytelling to heal is incredibly dramatic. And I know that, I keep coming back to this. You wrote some letters to your son. Can you talk about that process of writing those letters and what you said?
A good friend of mine who I got to know through Stanford, Trish Bryant, is what she calls a letter midwife. So she helps people write these kind of crucial letters at important points in their life. And I thought this was a great idea, fantastic. And so, and this is her class, Lasting Letters. So I sponsored that class because you need a faculty. So my name's on the class, but she does everything, and I never wrote a letter for myself. I never authored a letter to someone, and then I reached out to her after this. I got diagnosed, and she worked with me to write this letter to my sons. And I think the surprising thing, I've always talked with my wife about three things we want for our kids. One, we want them to be independent, of course, make sure they get launched out in the world. Two, we want them to be good people to carry our values with them, which, is kind of funny. We never have these conversations about values and being a good person anymore in this environment where it's probably even more crucial.
Yeah.
And three, we wanted them to be happy people. Like we wanted them to, and I have a belief there's, unless you have a chemical imbalance in your brain, dopamine and so forth, and you're clinically depressed. I think a lot of us can actually choose to be happy, and there are different things we can do to choose to be happy. So, my wish for my kids was to be happy. But one thing that came out of this letter writing process was my realization that the role, and we talked about this a little bit earlier, that serendipity played in my life. So, I would say this, I'm in the profession of giving advice, right? Doctors, our job is to give advice. But, we give advice that's evidence-based, right? Evidence-based on populations, but we try to apply that to individuals. But so I've never found kind of giving career advice that helpful. I was worried that, well, I'm giving advice about things that worked for me, right? But that doesn't mean they're applicable to anybody else at all, right? It's like anecdotal evidence, we call it in medicine, right? But, this is something that I thought, geez, it was so impactful to me to leave myself open to opportunity and serendipity. And it's really given me unexpected dividends in life, right? Starting the Center for Asian Health, right? That was not planned. I didn't really start out thinking I'm going to start this center. I had a patient who had a bad reaction to a drug and that I gave him. And then he came to me, he was very nice and said, hey, this reaction happens in people of Chinese descent. And, I know doctors don't know about this and not widely known in the U.S. And he didn't blame me. He said, hey, let's do something about this. And so that inspired me to say, hey, there's so many things that differently impact Asians in terms of health, like normal weight diabetes, lung cancer, nasopharyngeal cancer, and the list goes on and on, gastric cancer, heart disease in South Asians. And that inspired me to reach out to my colleague, Dr. Latha Pandiapan, because she has a long background in Asian health research. I had zero background before I helped start the Center in Asian Health Research. So just an example of serendipity, right? I took something and I said, hey, what am I going to do with it, right? I took something ostensibly bad and turned it into something, ostensibly good. Same thing with my cancer, right? I took something, that really sucks. It's horrible. I mean, I wish cancer on anybody, and it's horrible. But, I wanted to make some good. So again, serendipity, really, I view that as serendipity. I had this cancer. I had a background in starting classes. I thought, geez, it'll be helpful. I reached out to my students who TA'd some of my classes in the past. They were on board, and we started the class, right? So all of those components had to come together. With being director of medical humanities, I didn't plan to be, I have no research background in medical humanities. I didn't plan to be director. And the reason I did was I started working with a program, but before COVID, helping arrange tours of Cancer Art Museum at Stanford, helping bring attending doctors, attending physicians, my colleagues from primary care to events, to poetry reading and music events. And then during COVID, I knew something was kind of bad was going to happen to our mental health because we're all stuck at home. So 3 weeks, I reached out to Jackie Genovese, who's the executive director of our program. And I said, hey, we got to do something. We should have these home concerts on Zoom. And she worked with me to put it together. And it's almost like a variety show of all the talent we have at Stanford. And it was just amazing. We had so many people tune in week after week. And we even had the dean come and play the cello, which was amazing. And again, serendipity, that worked out well, worked on some other projects. And then, when Dr. Audrey Schaefer, who was the founder of the program, was retiring, she and Jackie said, hey, we really think you should apply to become director because, we worked with you and we know, how you could help the program. And I applied and was thankfully chosen to be director. But again, that's an example of serendipity, right? Starting my companies, example of serendipity because, I knew my latest company is called Sound Health, which you scan your face, figures out the resonant frequency of your sinuses and nasal passages, and you wear a headband that vibrates them and decongests you right away, medication free. But I would not have started this company if I did not know Peter Huang, Dr. Peter Huang, who's the head of rhinology at Stanford. And he brought in his patient, Paramesh Gopi, because we had talked about this idea of using vibration for the sinuses and congestion for years. And because I knew Peter and Peter knew Paramesh, and the three of us got together in the cafe at Li Ka-shing, and, we kind of came up with this idea. Really, Paramesh came up with this idea, so he kind of glued us together. That was really serendipity, right? And so, it's just, I really, through that experience of writing the letter with Frisch, I realized the role serendipity and leaving myself open to opportunity has played. And, of course, famously, Steve Jobs, talked about in his graduation speech to Stanford, that talked about how you can connect the dots going backwards, but, you can't really necessarily connect them going forwards.
Right. And it's interesting. This diagnosis actually, there is serendipity in that it allowed the things that you were most passionate about, that you were working on, to actually have a larger platform and to create even greater awareness for CARE, Center for...
And that was not intentional, right?
That was not intentional. Or this idea of the importance of humanities, right, in medicine. And both those platforms have been...
It all came together, right? I mean, so many stories, all of the media stories, they're stories, right? And they impacted people, but this was all unintentional. I didn't, consciously start the class with this in mind. I thought, geez, this would be a neat class. I would have loved to take it as a student. And my focus was really on what impact can I have on the students. And I think we're successful from the feedback we got from the students. But I'm really, really thrilled that it had a broader audience.
Yep. And I'm so grateful to have spent some time with you. You really are the idea of what you're talking about, how to live. You're showing us actually how to live, with a diagnosis as it is. You are actually being fully present. You're creating stories that are creating a legacy. And I just had one final question is sort of, I know it's not just this class. I know there are other things that have come from all the dots that you've connected in the past to right now, which is, I believe you're working on a book, and I think even is it Wayne Wong is helping you with a documentary, and I know you're fundraising for a cause that you really care about. Can you talk about some things you're sort of focused on right now?
Yeah, I think, I never intended to write a book, but working on a proposal now, and that came out of the New York Times article that was written about me. And again, my goal is, I don't really care about my notoriety, but it seems like my story has helped people. But I want to help people, and that's the kind of personal level, but I also want to help people on the scientific level because I'm an engineer, scientist, inventor. And, to do that, we need funding, unfortunately. Nothing's done for free. And, we need funding on two fronts. One, we need philanthropic support at Stanford. So if you go to asianhealth.stanford.edu, you can see all of the great things we do, not just for lung cancer, but all things we do to promote health in the Asian community. And so that's the kind of philanthropic mission. And then the other side is we really need more funding for early stage translational research. So my youngest son is in seventh grade, finishing seventh grade. In 5 years, he's going to graduate from high school. I want to live to see him graduate from high school, right? To do that, we need the next generation of drugs. Unfortunately, NIH is, not, the funding is going down at NIH, right? It's really the critical point. And so how do we do this? Well, we need not just philanthropy, which will help, but we also need more venture support of early stage research. So I'm actually working with a team to raise a small venture fund to support lung cancer, translational lung cancer research, to get those discoveries out of the lab into the clinic to phase 1 of the FDA approval process. And again, you'll find, I don't care about return. I don't care about money. I could retire. I've been lucky in my life. But you'll never find somebody more motivated than me to make this a success. So, if you're interested in that, please reach out to me. Trying to, work on all angles to improve the health of our community.
Well, thank you, Bryant, for all you're doing and what you're raising money for. It's this idea of, what you're going to do with it and the impact it's going to have. And it's clear the story that you are telling today and that you are part of and that you are the subject matter of is one that is creating great legacy and will have incredible impact. And I thank you wholeheartedly for having the podcast and what we're talking about today sort of to be your letter to our community. Thank you.
Great. Thanks for having me.
Listen to all episodes of Aconic on aconicpodcast.com. You can also catch new episodes on Apple, Spotify, or wherever you get your podcasts.